Hi, I'm Lloyd Michener, a professor of family medicine at Duke, and have long been working on community engagement as a method for improving health and reducing disparities, and most recently as an essential tool for reducing disparities due to COVID. At Duke, we've been working on engagement with the Durham and larger community for more than 30 years, adapting and responding as COVID hit. We helped establish one of the first primary care medical home networks, then evolved to partnerships with community organizations that seek to provide care in ways and places the community finds helpful and help link people to community resources for assistance with housing, food, jobs, and support, and now testing. These community engaged models of care are now not unique to Durham or North Carolina, have been replicated across the country, and have helped reduce chronic disease admission rates from minority communities by 50 to 80% or more, and are also now serving as the core of several city and neighborhood responses to COVID. Trust matters, and the process of building trusted partnerships is easy to describe, not particularly hard to do, but oddly counterculture in medicine. The first step is to learn about the community, its strengths and priorities. Communities have histories and often long and complex ones. You can learn a lot about communities through reading and research, but the best way to learn is to simply get out in the community and listen. Just as with doctor-patient communication, presence matters, and so do listening skills. The next step is to jointly plan services and programs. Unlike interactions with patients, community groups will disagree, challenge, and counteroffer, including with each other. Developing plans together takes time and patience. Next is to build and rebuild programs around community priorities. Needed programs usually include primary care and behavioral health, while community-based programs may include access to food, housing, legal services, and more. And the last is to begin, celebrate, and start another cycle of listening for how well we're doing and what we can improve. It's a quality improvement cycle with the community. What does this actually look like? Well, one early example was when Duke realized that many people were traveling past a very good primary care center where I worked to go to the Duke ER for problems that did not require ER care. We tried teaching them about primary care in medical homes, in our office, in ER follow-up calls, and in handouts and flyers with no success. Then we decided to go to the community and listen, and learned that that community, which is on the other side of the tracks from our office, had a deep suspicion of Duke. The Walltown community grew up around the home of George Wall, the black personal assistant of James B. Duke, who founded the university. Mr. Wall was never thanked or acknowledged, and the current members of the community, including his descendants, also did not appreciate our practice of publicly asking for payment and of requiring rescheduling if a mother was 20 minutes late for an appointment because the bus was late. When we asked what would work better, their clear answer was a clinic in their neighborhood, convenient to them, with a sliding scale and staffed by people like them. After more than a year of planning, we opened a restored home as the Walltown Clinic in partnership with our FQHC, the community churches, and the neighborhood associations. Duke also flew in every member of the extended Wall family to give overdue thanks for their family's contributions to Duke. That small clinic has been jammed since its first day, and the drop in ER visits was so striking the head of the ER called to ask what had happened. And while the program does require subsidy from the Duke Health System, the drop in minimally compensated ER visits make it a net positive for the health system. We've continued that support through rounds of expansions. The site is staffed by PAs backed up by family docs and is now a sought-after site for clinical rotations. We have multiple versions of these clinics across the city, as well as programs integrated into senior living centers, each a realized vision of what that community wanted and valued. COVID has tested these relationships, and we have responded by becoming centers of information and care and partners in advocating for the services needed by those they serve. In Durham, it was the community partners who pointed out that COVID was striking the Latinx community particularly hard, with 77% of the cases among the Latinx community, despite being only 14% of the county population. In response, Duke helped organize an advocacy and action group who lobbied for and received direct state support for outreach in Spanish for Mass, and now we're working on expanded testing. We're also now part of a partnership between the state and every healthcare provider in the state and over 2,000 community partners to accelerate rollout of a statewide platform to link people and patients with community resources for freezing out employment assistance and support. As of last week, the program is up in all 100 North Carolina counties. What we have relearned through all this, to our surprise and chagrin, is that trust, like good medicine, begins with listening. It also requires being trustworthy, being part of our communities, engaging in long-term partnerships to help our diverse communities build on their strengths and priorities. Building trust, like building healthy communities, is a long-term process. It's essential in disasters like COVID hit, and is something we can and must do. Thank you.